Hello, my name is Dr. Jeffrey Barsuk. I am a professor of medicine and medical education at Northwestern University Feinberg School of Medicine. I currently serve as the Director of Simulation and Patient Safety. I would like to welcome you back to the third podcast in our series on simulation and healthcare education. Today, we plan to highlight Chapter 5 on assessment and mastery learning, which is within our book called Comprehensive Healthcare Simulation, Mastery Learning in Health Professions Education. Today, I have the distinct honor of interviewing Dr. Celia O'Brien. Celia is an assistant professor of medical education and director of program evaluation and accreditation at Northwestern Feinberg School of Medicine. Celia, it's an honor to interview you today.
Thank you very much. It's an honor to be here.
So Celia, tell us a little bit about your background and how you got involved with assessment in medical education.
Sure. So my degree, I have a PhD in higher education from the University of Arizona. And of course, they teach you all about assessment and learning as you go through that degree program. I accidentally fell into medical education at the University of Arizona. And when I transferred over here to Northwestern in Chicago, I was hired within the Office of Medical Education for the medical students here at Feinberg to basically help them develop assessment instruments and evaluate the curriculum. And usually every medical school has one of me. They have someone with a PhD in education that helps them think about how to assess their learners and how to ensure that their curriculum is meeting the outcomes.
And of course, our medical students are very involved in simulation from almost day one of medical school, correct?
Oh, absolutely. We have them involved with simulation, ultrasound. They are learning how to do different procedures. We have weeks in which the curriculum is synthesized called SAM weeks, led by Dr. David Salzman, in which students are in the sim lab practicing procedures on the standardized patients.
That's actually a perfect segue because I just talked to David in a different podcast about the Thomas and Kern model. But today, I wanted to delve in a little bit deeper into step 6 of the model, which is about assessment and program evaluation. I was hoping we could talk a little bit about how to create assessment tools and how to ensure that our curricula produce data that's both valid and reliable. We've talked about mastery learning as a different entity because it's not based on normative grading. For instance, when I went through medical school, and most of the standardized tests I've taken have always been normative. And in other words, even the individuals that would get one standard deviation below the mean would pass the test. And we know that's just not acceptable in mastery learning. Celia, can you tell me a little bit how your take on this? How is assessment different in mastery learning?
Well, I think it's exactly as you mentioned, in which you're basically trying to compare the learner against a standard. You're not trying to compare the learner against a cohort or their cohort of peers. And we see that a lot with large-scale written examinations. For example, classical item theory, the way you would study the quality of an assessment is all about how learners are behaving against each other. And creating a quote-unquote, passing cut point based on a standard deviation, like you mentioned, where mastery learning is all about ensuring that every learner is meeting the same standard, however long that takes. It's going to take some learners much quicker than others, and some learners are going to need to repeat the procedure and continue to learn until they get there. But everyone's going to get there at the end. And you're not comparing against each other, you're comparing against the standard. Does that make sense?
Yeah, it seems like that would take a lot of stress off the learners, but I'm not sure. We often talk about assessment of learning, but I've heard Dr. McGahee talk about assessment for learning rather than assessment of learning. What's your take on that?
So assessment for learning, my interpretation of that has always been the feedback loop, that someone is going to be demonstrating a skill, and you can even do this with knowledge as well. You can demonstrate your knowledge, your skill, and you're going to get feedback on how that demonstration went. And from that feedback, you continue to practice. And then you're going to go through again and demonstrate that. So you're using the assessment as a feedback loop to move forward and to ensure that you're meeting the standard.
We talk often about assessment apprehension, and we know that, it's nerve-wracking to take tests and be watched. And certainly in medicine, and foremost in a high reliable system where we can't make mistakes when we take care of real patients, it's really important to get used to assessments and be comfortable with them and think of them more as a formative way to help you become better rather than using the data from the assessments as a weapon rather than as a tool for learning.
Yeah, I mean, I think it's extremely nerve-wracking to either you sit down once to demonstrate your knowledge. So that's assessment of learning, right? You sit down once and you demonstrate something, knowledge or skill, or you walk into a sim lab and you demonstrate it once and that's it. And then you're sent along your way, where I think what we're trying to cultivate here is the idea that you can come in, you demonstrate something. It may not be up to the standard yet, but that's okay. And then you continue to practice, and it's sort of creating a safe space, a place where learners can feel that it's okay to not be at the standard yet, but you're going to get there.
Yeah, I really take that pre-briefing before my simulations to try and create that safe environment and let them know why we do a pre-test and we do frequent assessments. And as generations come up more and more being used to assessments, we're seeing that there's much more comfort doing more and more assessments for learning.
Well, yeah, you think about the way it used to be where people would, I mean, I'm sure I obviously did not go through medical school, but I'm sure that the number of assessments you probably had when you were going through medical school and residency was very different. And it was, some multiple choice exams and an OSCE maybe, and you would get some feedback from your preceptors on the clerkships. But I think that we're really trying to implement more and more assessments and making that more part of the culture. And I'm glad to hear it's coming up from the undergraduate medical education level. It's coming up to what you're seeing in your residents, fellows, and attendings in the sim lab.
Well, now let's shift a little bit and talk specifically more about creating assessments, because this seems like a daunting task. But I think we can maybe simplify it for our listeners to make it a little easier. How do you particularly differentiate between creating assessments of skills versus knowledge?
This is something that comes up so often. So I work a lot with residents and faculty who want to develop a curriculum and develop an assessment instrument. And it's a very common thing where you need to make sure that the instrument or the method that you're using to assessing is properly built for the construct you want to measure. So, for example, we are often conditioned to think of assessments as examinations and assessments of knowledge. That's the most common way that you might assess something. So you want to assess that somebody knows something. And oftentimes the residents and faculty will be creating a curriculum to try and change behavior, but they're writing the items on their assessment forms to measure knowledge, not behavior, or measure knowledge, not skill. So you really have to think about what's the end result? What is the end result that you're trying to measure, and map and make sure that your assessment form is mapped to that. If you want somebody to show you how they're doing something, then your assessment forms need to be able to observe, capture that observable behavior in a rating, in a time measurement, however you decide you want to measure something. It needs to map to the behavior you'd like to measure.
So that gets back to what I talked about with David Salzman about the Thomas and Kern model, is that all the steps are intertwined and go back and forth. So essentially, I think what you're saying is step 6, which is the evaluation and assessment part, actually has to be directly tied into step 3, which is your goals and objectives.
Absolutely. And actually, once you get used to thinking about learning objectives, to me, when I was just starting out, were abstract things that you kind of wrote hurriedly down and didn't think about it again. But those action words that you're using to create your learning objectives should absolutely guide the kind of assessment you develop. In fact, it really needs to be one and the same. You should already have in mind how you're going to measure your learning objectives. So if they're truly going to be measurable, if you're asking someone to list, the steps it will take to, well, give me a procedure here.
Central
Yeah.
line insertion.
Yeah. If you're going to try and ask someone to list the steps at central line insertion, that's a knowledge. That's something you could just write down. You don't need to observe that, right? But if you're going to ask someone to correctly, insert the central line, insert is a behavior. And I'm not using probably the best, most robust action words here, but I think you get my point. The way you're writing learning objectives should absolutely guide the way you're developing your assessment instruments.
So if the learning objective uses a verb that's about knowledge, you would use a written examination, for example. Whereas if it uses a verb that requires a skill, like a demonstrate, then maybe a skills checklist is best. And I'll say in simulation, we often use skills checklists because simulation is probably best for skills. You can embed some knowledge components into your skills checklist, but I like to separate them. But sometimes knowledge is intrinsic to the procedure. An example would be decision making. Like if you're doing an advanced cardiac life support exercise in sim, recognizing an arrhythmia would be knowledge based, but then acting on it to show that knowledge would be skills based. And you can actually test that on a skills checklist.
Yeah, absolutely. And, I think, again, depending on what level your learner is, you can decide what you want to assess.
So let me just shift a little bit to creating checklists, because I want to get into how we, at least at Northwestern, have created checklists that we believe to produce valid and reliable data. So we like to use the Stufflebeam method. It's like a checklist for checklist method. And it involves about 8 steps. First, we'll define our task. Let's say it could be any procedure like central line insertion. And defining your task really should be about the learning objectives. And then we review the literature to make sure that we have the best evidence and the best practice. Maybe there's a checklist already out there that we can borrow best practices from and adapt. And then draft the checklist is the 3rd step. And then the 4th step is having experts review the checklist and come to consensus. The 5th step is pilot testing and getting feedback not only from the learners, but from the raters. And then revising the checklist, calibrating the checklist among the various raters, and then again, revising the checklist. So that was a total of 8 steps. And the biggest key is the last step, revising the checklist, because that has to happen periodically because the literature advances and techniques change over time. But specifically when we do that, Celia, you can kind of see how those steps intrinsically have the ability to ensure we create valid data. Can you talk to that a little bit?
Yeah, and first of all, I should say that I love talking about validity, and I love talking about how to gather validity evidence. I think when I was first in school learning about these methods, it was very intimidating to me because I assumed it was all about gathering quantitative data and running very complex statistics. And it's really not. It's about gathering evidence to make sure that you are producing defensible decisions. And that's something that I'm sure that you're going to be talking about on this podcast a lot throughout your entire curriculum development. You're continually gathering evidence to support your argument that this curriculum, that this instrument is making defensible decisions about learners, because these are, as you mentioned, high stakes decisions. So I don't want people to be too intimidated by the concept of validity. Those steps that you just went through, I think, are very intuitive. I think it's nice to have them mapped out for people, but they can be almost perfectly mapped to the evidence that you would gather in your validity argument. So, for example, I'm going to take the first 4 steps, which were, as you mentioned, defining the task, making sure that the task that you want to measure is very clearly defined. Reviewing the literature, first of all, not only to see if there's an instrument out there that's been developed, but also to make sure that your task that you're defining is defined as well by other colleagues and experts in your field, I think can be helpful. And then the 3rd and 4th is really drafting and reviewing with experts. So, you do not want me, Celia O'Brien, by herself in a windowless room coming up with a checklist and deciding this is it, this is what we're going to do. No one else gets input. And really, this has a lot to do with what in validity terms we call content validity. So on its, in and of itself, as the content of your checklist, is it defensible? Have you had it vetted by others? Is it rooted in the